All right, so I think we'll start 5 minutes early, and with each presentation, we'll probably gain 5 to 10 minutes, and then we'll be out of here a little earlier too. So please welcome Dr. Kevin Strawn to the podium. Dr. Strawn is from here in this Raleigh area, and he is passionate about what he's talking about. Because there have been, even from the time he wrote his presentation, there have been changes that he has updated. And I do want to say just briefly that your notes, those of you who have notes printed or you're looking at notes, I'm sure you have noticed that things have changed for some of the presentations versus your notes. And that's just because of I'm sure you've noticed that we have outstanding presenters too, and that just has to do with their passion for what they're doing and making sure they get you the most current and correct information. So please help me welcome Dr. Kevin Strawn to the podium.
Can you all hear me okay? All right, well, thanks, Judy, for the introduction. Like she said, I'm Kevin. I'm from the Triangle area. It's a great place. Hopefully you all have been able to enjoy it a little bit and it hasn't been too hot. But yeah, so we'll talk about USP 800. I heard you had a 797 talk yesterday. Maybe not the most exciting things, but very relevant to pharmacy. So before we get started, I wanted to see how many of you have heard of USP 800 before this presentation. Okay. That's great. I'm glad to hear. Now, how many of you are in hospital or health system? Okay, the majority. How many of you are in community pharmacy? Okay, a few. We'll talk about community pharmacy too. I know there's been some trepidation about community pharmacy USP 800, so hopefully I can address that a little bit. How many of you have your health system or community pharmacy have started to implement USP 800? I hope the technicians at Duke Regional raise their hand. Yeah, so about 50-50. Potentially going to be enforceable in 2023. I know yesterday you talked about USP 797, and we have to wait until that becomes enforced. So the new update for that becomes enforceable, but we'll see. It's coming one way or another. So with that, I'll go ahead and get started. I don't have any disclosures. And this presentation was adopted from slides by Jordan Carrera, who's another pharmacist at Duke Regional Hospital. And so I want to thank him, even though he's not here. I adapted them for this presentation, but a lot of the slides I took from him. So a little bit about what we'll be going through. I'll give you a brief introduction to USP 800 for those of you who aren't familiar, and for those of you who are familiar, just to make sure we're on the same page. We'll review from a high level the elements of USP 800, and then we'll apply USP 800 to clinical practice throughout the presentation. This talk is really a very high level. We're not going to get into too much of the nitty-gritty of spills, waste disposal. We're definitely not going to talk very much about nursing administration, because those could all be hour, 2-hour presentations. So hopefully you take away that, yes, this is going to be some work for us at our health system, and we need to go ahead and get started on this. And you can join the committee. We always love having more people on the committee. So we'll talk about when USP 800 applies, when it applies to hospitals, and when it applies to community pharmacies. We'll go through all of the elements kind of USP 800 from receipt to disposal. And then we'll talk about some other additional guidelines. So what have you all, this is going to be, you can raise your hand or just call out, what have you all heard about USP 800? I see some chuckles. I don't know if that's a good thing or a bad thing. Yeah, so
In addition, some of our processes change where, as in the past, it was a routine task in pharmacy, maybe to split finasteride tablets.
right.
If the patient dose was 2.5 milligrams or whatever, and we quit doing that altogether. If the patient had that kind of dose, it would be split on the floor by the nurse, not the pharmacy. So there were changes beginning to occur.
Okay, yeah. So, like she was saying, it goes all the way from receipt and unpacking to administration and preparation of tablets to disposal of medications and packaging that the medications were in. And yes.
There's one more thing that I found very interesting. Patients that were taking these medications had to wear a visible sign so that if they were in the hallway or they were walking or they went down to the cafeteria, that people would know that they had been administered or ingested hazardous medication.
Oh wow,
I found
that's very thorough. We still have some more to implement, but we have not been planning to make patients wear a wristband. We'll see kind of once we talk to other departments, because we really just focused on pharmacy because we're pharmacists. So we focused on pharmacy, but we'll see what happens when we go to other departments and what they want to do. So I pulled this screenshot off of Reddit, and it's maybe, hopefully, no one takes offense from this, but it says, if you were involved in the making of USB 800, I officially hate you. I think there's some pretty strong opinions out there because it is far-reaching changes for the whole hospital or community pharmacy. But hopefully at the end of this presentation, you'll see from a pharmacy standpoint, it's maybe not quite as bad as this person is making it out to be. So what facility? So USP 800, the purpose of USP 800 is to protect the pharmacy department, nursing department, anyone that works at the hospital, and any patients at the hospital from being unnecessarily exposed to hazardous drugs. And so that's it. We are trying to protect you all, me, and the patients. It kind of gets a bad rap because there is a lot of implementation required, but it is for us. It's not like USP 797, which is to protect the patients from infection. This is for us. So we really should be invested in this and do the best that we can to make sure that everybody is safe. So USP 800 is not enforceable yet. USP 795, which the revision is not yet enforceable, refers to USP 800. So when USP 795 becomes enforceable, USP 800 will be enforceable for facilities that compound non-sterile products. So any retail pharmacies that are doing any sort of compounding, that can be as simple as combining a lotion with a steroid cream, that is compounding, then USP 800 will apply to you all. Now, what I think is going to happen is retail pharmacies are going to say, nope, we're not doing any compounding. We're not going to do anything with USP 800. We'll see. We'll see what happens. USP 797, the revision is also not yet enforceable, but it also refers to USP 800. So when that revision becomes enforceable, then anywhere that compounds sterile products will have to follow USP 800. And my understanding is once these two become enforceable, there's a 6-month grace period before USP 800 will become enforceable. But then yesterday, my manager was saying that USP 800 has been postponed again, maybe indefinitely. I don't know what that means. So, you may have heard this was going to go into effect in 2017, and here we are in 2022 still talking about the implementation. So a quick question here. Once USP becomes enforceable, what pharmacies will be exempt from the rule? And there is a typo on your slide. C should say no HD medications if you printed out your notes. So I'll just ask you to raise your hand when we get to the correct answer. a hospital IV room that prepares sterile HD medications, a community pharmacy that compounds non-sterile medications, an outpatient hospital pharmacy that dispenses no HD medications. I see a couple hands for that one. And then a cancer center pharmacy that only compounds chemotherapy. So our answer here is an outpatient hospital pharmacy that doesn't dispense any HD medications. They won't have any hazardous drugs. USP 800 won't apply to them. Now, is that really feasible that you can get away from hazardous drugs if you're a pharmacy? No. Clonazepam is a hazardous drug. Clonazepam. Let's see. Finasteride, yeah. Warfarin, paroxetine is a hazardous drug. So we're talking about medications that every single pharmacy is going to have. So it might be better to say a hospital pharmacy that doesn't compound any medications would be exempt at the current time. Now, the North Carolina Board of Pharmacy does recommend that every pharmacy implement USP 800 because they think eventually the North Carolina and other legislatures will pass a law saying USP 800 is enforceable. But at this time, that is not the case. So what are hazardous drugs? So there are multiple lists out there that list hazardous drugs. The two that I've chosen to highlight are NIOSH, which is the National Institute of Occupational Safety and Health, and ASHP, the American Society of Hospital Pharmacists. So I'm not going to go through and read this. We'll go through the NIOSH categories in a minute, but USP 800 specifically refers to NIOSH. So any medication that's on the NIOSH list that your hospital or community pharmacy carries needs to be on a hazardous drug list that your institution makes. And USP 800 also says you can't just take the NIOSH list and say, oh, this is our hazardous drug list. We might have some medications on here. They say you need to pick the medications off the NIOSH list that your institution has and list them separately so that your staff knows what to watch out for. Now, we have created our hazardous drug list, and I think it's about 100 drugs long or so. So it's quite a lot. No one's going to be able to remember every medication on our list, let alone the NIOSH list. But we're working through that. We're hopefully going to get hazardous to print on the labels. So what medications must be included in a facility's hazardous drug list? Medications on the NIOSH hazardous drug list, medications deemed by the facility to be hazardous, pregnancy category C medications, or A and B. A and B, yeah. So USP 800 doesn't, so they only say that you have to look at the NIOSH list. But there are medications that are not on the NIOSH list. Some birth control medications aren't on the NIOSH list, whereas other birth control medications are. And then pentamidine is not on the NIOSH list, which I thought was very interesting, because if you all are familiar at all with pentamidine, it's used to treat PCP in usually patients with HIV, and it's nebulized, and it has to be nebulized in a negative pressure room, and anybody that goes in there but the patient has to wear a respirator. So I'm not quite sure why it's not on the NIOSH list, but it's not. And then other medications that aren't on the NIOSH list are any antibodies. So NIOSH, on their update that's coming out in 2022, 2023, they're going to remove any medication that's an antibody from their list. And so if you all are familiar at all with cancer medications, there are antibody drug conjugates, where you have an antibody and they attach a really toxic molecule to it. So those medications are definitely hazardous, but they are not going to be on the NIOSH list. So my recommendation is your institutions are going to be going through all this work to implement USP 800. You all should include these other medications that might not be on the NIOSH list, yet are still hazardous. Unfortunately, that's just how it's going. And so A and B would be the recommendation. A is a must. You must do that. B is it's in your best interest since you're going through all this work anyway. And so the NIOSH list is a list of all the hazardous medications that this organization recognizes as hazardous. And so there are 3 categories on this list. Category 1 is anti-neoplastic drugs, which is chemotherapy. Category 3 is reproductive risk drugs, which is only hazardous to women of childbearing age, really women who are pregnant or trying to become pregnant. And that would be something like clonazepam or paroxetine. And then category 2 is everything else. Now, unfortunately for us, NIOSH is coming out with an update, and they are combining category group 2 and group 3 medications. So we won't have that nice delineation between medications that are truly hazardous to everyone and medications that are only hazardous to pregnant women. I'm not quite sure how that's going to look in practice, but that's something each hospital and health system and community pharmacy will have to deal with independently. So the scope of USP 800, as I've mentioned a couple times, everything at your institution, when a hazardous drug comes in the door to when the hazardous drug is taken away by waste management, is governed by USP 800. So that's receipt, storage, compounding, dispensing, administration, and disposal. And so you can see this goes far beyond just pharmacy. USP 800 requires there to be a designated person at your institution to oversee the implementation and compliance with USP 800. And at first we thought, oh, this can be a pharmacist, but we don't really think that anymore. We think it needs to be a compliance officer who has more knowledge with nursing staff, procurement, and waste disposal, as well as pharmacy. So that would probably be the recommendation, is to try and get a compliance officer to do that. Now, is that feasible for our institution? I'm not sure. We still have to go to all these other departments and determine who's going to be doing that. But this is what USP 800 governs. And so entities that handle HD, hazardous drugs, must incorporate standards into their SOPs or policies and procedures so that you have set documentation for what needs to occur. So like I've mentioned a couple times, you need a list of hazardous medications that's specific to your institution. And we've struggled a little bit with this because sometimes we'll get in medications that are in a bulk bottle, so you have 100 tablets in a bottle, but sometimes we'll get in medications that are unit dose. And they're the same medication, but they're in different forms. So what do we do with our hazardous drug list? And, I don't know if it's correct or not, but we decided to just list everything on there that we could possibly have, this formulary. So that is a little bit of a challenge, but you all will have to decide what's best for your institution. You have to have facility and engineering controls. So this is going to be things for your IV room, things for unpacking, like the person was talking about at the beginning. You're unpacking special areas. Competent personnel, so we all need to be trained in USP 800, specifically how to handle hazardous drugs. Safe work practices, so that if there's a spill, if you're compounding, things like that. Proper use of PPE. So we will talk about this when we talk about the assessment of risk, but the USP 800 says when you're handling hazardous drugs, you need to wear gloves and a chemo gown. You can get around that a little bit for certain medications with an assessment of risk, but you still need to be wearing appropriate PPE. And then policies for waste segregation and disposal. So hazardous drug waste needs to go into a hazardous drug bin. You've probably seen these at your organization. They're yellow, and they say hazardous drug on them. And so entities must maintain a list of hazardous drugs, NIOSH list, and any other identified hazardous drugs. Like I was saying, there are lots of lists out there. You have to review this list every 12 months, and it has to be updated. Potentially more if you're having new hazardous drugs come in. You have to evaluate every medication that comes in on your formulary to see if it's a hazardous medication. And then if you store, prepare, or administer a hazardous drug and it's not going to meet all elements of USP 800, so that means if you're going to do anything outside of a hood, like one of those big hoods, you need to do an assessment of risk. So as you can imagine, paroxetine doesn't need to be, you don't need to garb up in a chemo gown with gloves on and go into an IV room and count out paroxetine in a hood. So you're going to need to do an assessment of risk on paroxetine to say this can be done outside of a hood, maybe with just gloves and a mask on. But we will talk much more in depth about that. So sterile and non-sterile hazardous drugs must be compounded within a containment primary engineering control inside of a containment secondary engineering control. So I know that's a lot. Hopefully you got a little bit about this information from the 797 talk, but the primary engineering control is going to be a hood that you would work in, and then the secondary engineering control is going to be the room that the hood is in. And so you have to have a certain amount of airflow changes in that room, and your hood has to be not blowing out at you because these are hazardous drugs, but it has to suck all the air down so that you won't be exposed to these medications. Closed system transfer devices must be used when administering hazardous drugs when the dosage form allows. So what that means is chemotherapy needs to be administered, IV chemotherapy needs to be administered with a closed system transfer device. And I have a list later on of closed system transfer devices, but EquiShield, Chemoclave, and Spiros are a couple examples of those. PPE, and so when compounding hazardous drugs, it's not required to use a closed system transfer device, but if you're going to do it for administration, you might as well do it for compounding, because otherwise you would have to attach it after the fact, which doesn't seem feasible to me. PPE must be worn during receipt, storage, transport, preparation, administration, and disposal. You must have proper policies and procedures. We talked about that. You must deactivate, decontaminate, and then clean areas where hazardous drugs are handled, and we will go through that a little bit more later in the presentation. And then I'm not going to talk much about spill management, but just know if a spill occurs, someone needs to know how to clean that up at your institution. Whether it's nursing, pharmacy, or environmental services, someone needs to clean up spills. We've decided to split it up to where the spill happens, that department is required to clean it up. So the assessment of risk. So the assessment of risk, like I said, is used when you're not going to follow everything in USP 800. The assessment of risk can't be used for active pharmaceutical ingredients. So that's going to be like powders, and this would be more for like 503B compounding facilities that are compounding lots of medications. The assessment of risk also can't be used for any antineoplastic, any chemotherapy requiring manipulation. So that basically applies to IV chemotherapy. You can't do an assessment of risk. You have to follow USP 800. It has to be compounded in an IV room, in a hazardous IV room under a hood. I mean, that makes sense because it's very hazardous. You can do an assessment of risk for everything else on that list. So you can do an assessment of risk for tablets of chemotherapy as long as you're not splitting them or crushing. I mean, you should never crush them, but as long as you're not splitting them. And the assessment of risk must include the type of hazardous drug, the dosage form, the risk of exposure, which is not 100% clear. We kind of struggled with this. If you're doing the assessment of risk properly, the risk of exposure should be very minimal. You shouldn't be putting people at risk of exposure to these hazardous drugs when doing your assessment of risk. Packaging, so does it come in a bulk bottle, a multi-dose vial, that type of stuff, and what type of manipulation will be done. So we have another question here. If you want to raise your hand when we get to the correct answer, what type of activity does not require an assessment of risk? Dispensing HD unit dose tablets from an automated dispensing cabinet, so that would be like your carousel or the floor. Compounding chemotherapy in a hazardous IV room. Splitting a tablet of warfarin in a negative pressure room. Or storing hazardous medications in the main pharmacy. And so I was going through the presentation yesterday, and I read this, and I was like, I don't know what the correct answer is. But the correct answer is B. Compounding chemotherapy in a hazardous drug room does not require an assessment of risk because you have to follow all USP 800 standards. Any of these other things are not following all USP 800 standards, so you are going to have to assess the risk to the person doing that and say that it's okay. So dispensing HD, so hazardous drug unit dose tablets from an automated dispensing cabinet, pharmacy staff is never really going to come into contact with the hazardous drug if it's in a unit dose, like packaged container. You're going to pull it out of the automated dispensing cabinet or put it in there, and then it's going to be ready for the nurse to pull it out. Splitting a tablet of warfarin in a negative pressure room, you're going to need an assessment of risk for this because warfarin is hazardous, but it probably doesn't need to go into a hood in an IV room. It's probably okay to do it in a negative pressure room with gloves on, plus or minus a gown. That's something your institution will have to determine, plus or minus a mask. So that's okay. And then storing hazardous medications in the main pharmacy, you would need an assessment of risk to do that as well. So this is an example of an assessment of risk. And before we go too much into it, this is not the type of form we chose to go with. Because with this type of form, you have to make a whole new form for each medication. So it's a lot of work, and it's not very user-friendly when a pharmacist or a technician or a nursing person needs to go find the assessment of risk. So what we went with was we went with a table. So we combined our hazardous drug list with our assessment of risk form. And so I will do my best to walk you through this. I've spent about 7 months working on it, so stop me if you have any questions. So let's see, can I get a mouse? No, it's not going to give me a mouse. So you can see in the top right corner, you have to have the review annually by. Then you can see in the bold packaging is how the medication is supplied. I've listed all the types of different packaging that occur throughout our hazardous drug list. And then you can see below that the NIOSH type of HD, which we talked about earlier, the Table 1, Table 2, and Table 3. And then alternate containment strategies. We have a separate table, which I'll go through, to talk about the alternate containment strategies. Okay, so now for the table, we have the date added just because it's nice to know, was this an original medication that we had on this list, or was this added later? We have the drug name, type of formulation, and so we have a bacavir sulfate, and I should add tablet or capsule here, but I don't have that on here. Then we have how supplied, so MD is multi-dose, UD is unit dose. Ideally, everything would be unit dose because then it can be stored in the carousel or in automated dispensing cabinets, and you wouldn't have to put that into a special storage location. Then I have the NIOSH list, the final location. So that's not required for this USP table, but that is so that our pharmacists and technicians can know where to locate the medication because we moved everything, all of these medications. And then I have our alternate containment strategies and work practices. And so we decided to just go about this by listing a letter for each of these medications. And that letter will tell staff what they need to do for that medication. And so here are the letters. It looks like a lot, but it's pretty simple. So A, that is IV chemo. You have to follow everything in USP 800, so it has to be prepared in a hood in the IV room. B is oral liquid medications. So we are storing these in our negative pressure room, but they have to be drawn up in the IV chemo room. C is bulk bottles of tablets or capsules. They are stored in our negative pressure room, and they can be counted out in our negative pressure room. If they need to be compounded or cut, they have to go into the IV room, and I say that in there. And then D is unit dose medications, which are stored in our carousel or in our automated dispensing cabinets, and they shouldn't be manipulated, crushed, or cut after they're taken out of the packaging, except in the IV room. We can do that. So I'm going to pause right here. I know this was a lot, and I kind of went through it fast, but I'm going to see what questions do you all have about the assessment of risk, because this is a big thing for pharmacy. Okay. Yeah. Oh, sorry. Yes.
Too far off the slide. When you have your
Yeah, so that is a great question. The question was, when we have hazardous drugs unit dosed in the carousel, what are we doing to denote them as hazardous drugs? So currently our plan is to mark it with a hazardous drug sticker. Eventually, we would like to get it to print on the label that this is a hazardous medication. We've run into some resistance with the health system because they're not quite, they haven't implemented everything that we've implemented yet, so they don't want to put hazardous medications on everything, have it go up to the nurses, and the nurses be like, what do I do with this hazardous medication? So eventually, we would like to have hazardous print on the label. Then, you know, when the technician goes to pull it or the pharmacist goes to pull it, they know they're dealing with a hazardous medication. Now, that being said, the technician or the pharmacist or whoever pulls it from the carousel should never be exposed. They should not open it in the pharmacy. But yes, we do want to alert people to know that it's hazardous, because we also want to let nursing know that it's hazardous, because when they're administering it, if it's a hazardous medication, they need to make sure they're putting gloves on and not dropping it on the floor or dropping it on the patient. You know, crazy things, for those of you who haven't worked in the hospital, crazy things happen during medication administration. But yes.
I have a question. I've worked in two different facilities last year. One was a retail pharmacy or a community pharmacy inside of a hospital.
Mm-hmm.
The other is a retail pharmacy in a store.
Okay.
The hospital one has all their hazardous medications in red trays, so they're clearly distinguished as such. When we had to dispatch them, we had to go to a special table, we had to glove,
Mm-hmm.
we counted them out, then we had to clean our counting tray with bleach and then alcohol
Right.
between every fill.
So that's what should happen.
Okay, so in the retail one, they're not in separate trays yet.
Mm-hmm.
They're labeled with a NIOSH label on the thing, but it's a small label and they're in with everything else.
Right.
And when we count them, we have a hazardous count tray, and they're cleaned with small alcohol pads, but we don't wear gloves, and they're done at the counter with all the other medications. So is one an overkill, or is the retail one going to have to catch up?
So I'm going to repeat the question real quick. The retail one, in my opinion, is going to have to catch up. So the question was, so she's worked in a hospital where they have their hazardous drugs clearly labeled. The hazardous drugs are counted out on a separate tray, and they wear gloves, and then after they count it out, they wipe it down with bleach. Then in the retail setting, the hazardous drugs are kind of labeled. They count it out on the normal table, and then afterwards they wipe it down with alcohol. So the first way is appropriate, and that is what should be happening. Now, like I mentioned earlier, USP 800 isn't enforceable, and even when it becomes enforceable, it will only be enforceable for retail settings that do compounding. So if your retail setting doesn't do compounding, then they won't have to follow it. Now, I don't think it's that hard. I don't know your experience, but it doesn't sound like it was much extra work to count it in a separate area. Yeah. So that's why I said, really, your facilities should be doing this. It is appropriate to wipe it down with bleach to deactivate and decontaminate the area. That USP 800 does say that. And then wearing gloves is best practice. And doing it in a separate area is also best practice, because if you don't know, you might have missed something. It might be a little bit of hazardous drug left over. So hopefully that answers your question.
I'll take that back.
Yeah. And hopefully after this presentation, you'll see that it's not too hard for a retail setting to implement this. For hospitals, yeah, it's a challenge, but for retail settings, I don't think it's going to be too hard. They're going to have to make an assessment of risk for all the medications, but you won't have to do anything in a hood unless you're compounding, which I wouldn't recommend. You won't have to do anything in a hood. You just wipe it down with bleach, maybe wipe it down with alcohol afterwards, and wear gloves. And that's really it, and label your medications. Okay, any other? Yes?
Foresee a time where the burden of this would be placed on the manufacturers, that the default tablets would only be available in unit dose. I mean, that would be stated. Now, in retail, unit dose is always more expensive.
Right.
But you know, if your only option was unit dose, and it was done at the manufacturer, it would just solve.
Yeah, so the comment was, or the question, can you see a time that we will only have hazardous unit dose medications? There won't be any bulk bottles. And so Ginger, I've worked with Ginger on this. She's back there laughing because I've asked her to order everything she can unit dose. Because it makes you just put it in your carousel and you're done.
I would like to answer that for you.
Yes.
First of all, if you make unit dose, it'll be a lot more expensive to make. Right now, the insurance don't pay for the regular one. They will not pay for the unit dose.
Yeah.
And believe me, I'm a microbiologist. I was a scientist. I'm a microbiologist chemist from the Harvard Pharmaceutical.
Right.
Believe me, I used to test those drugs. And believe me, it'll take a longer time to get approved. And you don't want to go there.
Yeah, yeah. So we have seen unit dose, and correct me if I'm wrong, Ginger, can be up to 10 to 20 times more expensive than a bulk bottle. So it's quite a bit more expensive. Does it make things easier for the institutions? Yes. I agree. I don't think manufacturers are going to go to only unit dose. I think they're going to keep doing bulk bottles because patients can still, like, this does not apply to patients. So they can still get bulk bottles and do whatever they want at home. This is really a problem for pharmacists and pharmacy technicians to deal with. Manufacturers are supposed to, when they ship, label their container that it contains hazardous drugs, but like you said, you don't know what's in there until you open it. So unfortunately, this is going to be a challenge for us going forward because I don't think it's going to be resolved. Yeah.
Another thing they're doing now, they're having the robots come down. So this way the
Mm-hmm.
people get in contact with them.
Right.
The robots come down.
Yeah, and so we also have a small robot that we do pre-packing with, and we've struggled with determining if we can do repackage hazardous drugs on that. Because it's like you were saying, you have to wipe it down each time you do a hazardous drug with bleach to make sure you're getting all the residue away. So for pharmaceutical companies, it's great that they just have the robots count it out and package it. We're a smaller hospital. We have 369 beds, so we don't have quite the capabilities that Duke University Hospital has, where I believe they have their own prepacker for hazardous drugs. We have one prepacker for all of our medications, and so we are currently in the process of determining how to prepack hazardous medications. Yeah.
When you do your assessment of risk, do you do that for what goes in the Pyxis machine too?
Yeah.
For if the packaging rips or?
So that's a good question. If the packaging rips, we did not assess if the packaging ripped what would happen. I don't know what the right thing to do is here, and there's not a lot of guidance out there. There's USP 800, and then there are presentations like this where we're all doing the best we can. So we're not pre-packing any hazardous medications, so we shouldn't have any packaging rip. The chance that that happens, we're saying, is so small that we're not going to address it. I mean, yeah.
I'm very small hospital, 25,
Mm-hmm.
2 beds, it's suite beds, no robot, no carousel. But one thing we did it quite a long time ago, was we took hazardous drugs and in the Pyxis, the QBs are all marked.
Uh-huh.
So at least the nursing knows,
Right.
because everything comes directly from pharmacy and everything comes from us packaging ourselves.
Mm-hmm.
And we have worn gloves for a long time and clean. So we did do, and when the Pyxis is open, the nurses do know if it's a hazardous drug, because they're not going to remember it.
Right.
You know, that nurse is going to remember Prostar is not pregnant, you don't want her in.
Right.
So my boss years ago, probably 3 or 4 years ago, we put hazardous on top of every QB that had
Mm-hmm.
anything,
Yeah, and that's probably, so for the recording, she said she works at a very small hospital, about 25 beds, and they have labeled in their Pyxis hazardous on every medication that's hazardous. And that, for nursing, is probably what should happen. There are a lot of little steps that need to occur for USP 800 to be implemented in hospitals. But that would be nice if we could get there. We are going to talk to nursing next. That's our next step. We feel pretty good about the pharmacy part. Now we're going to reach out to the other parts. So that's good to hear. All right, I'm going to pause for there. We can take more questions at the end because I do have a few more slides I want to get through. So types of exposure. Exposure can occur during receipt, dispensing, compounding, and I'll go through this in more detail, so I'm going to skip the right side. Administration, other patient activities, and then spills. And we will talk a little bit about spills, but that is a whole nother presentation. It can also occur during transport, so institutions should be tubing liquid hazardous drugs, because if it breaks in the tube system, you've got a big mess. Tablets of hazardous drugs, that's up to each institution, whether you want to tube that or not. I don't think USP 800 makes a firm statement about that. And then waste, any contaminated hazardous equipment, not equipment, but any contaminated hazardous gloves or gowns should be disposed of in a hazardous drug waste bin. So the chain of custody, as we've seen a couple times, receipt to disposal, and we'll kind of go through each of these in depth. So receipt, so this is our MOO, which stands for Mike's Old Office. We never came up with a new name. Mike, our director of clinical services, used to have his office in here, and then he got moved, and they made this our hazardous drug room, and it stuck as the MOO, and we've put it in our policies and procedures as the MOO. And if somebody said the hazardous drug room, the other people would be like, "Ooh, what's that?" But the MOO, everybody knows what the MOO is. So hazardous drugs must be unpackaged in a neutral or negative pressure room. So we just went ahead and said you need to unpackage hazardous drugs in a negative pressure room, which is what this is. And hazardous drugs can't be unpackaged in sterile compounding areas unless you're concerned about the package coming in broken. Then the recommendation is to take it into the non-sterile hood and unpackage it there. So this is what I was talking about. The shipping container should come to you intact, ready for you to unpackage. It should say hazardous on it, and you should know. If it comes to you damaged and you're worried that like a vial is in there that's leaked, like a chemotherapy vial is in there that's leaked, you should contact the manufacturer and see if it can be returned. Returned in some sort of plastic container so that it doesn't contaminate FedEx or whoever it gets returned by. If the supplier won't take it back, then you just have to throw it in the hazardous drug waste. If you must open it, the recommendation is to seal it up, take it into your hood, and open it there. That could be if you think only some vials are broken, but other vials are salvageable. Then you need to deactivate, decontaminate, and clean the hood. So deactivation and decontamination can be done with the bleach wipes that we were talking about, or preempt, I believe, which we'll go over in a bit. Storage. So hazardous drugs must be stored to prevent spillage and breakage. And the recommendation is in a negative pressure room. I guess you could do an assessment of risk and say you're going to store tablets and capsules in the normal pharmacy, and that's what retail pharmacies are going to have to do. They're just going to have to store them in the normal pharmacy, but they will have to do an assessment of risk to say it's okay to store it there. So where should hazardous drugs be stored and unpacked? A, in a neutral negative pressure room. Yep, in the neutral negative pressure room. You shouldn't unpackage them in the sterile IV room unless you're concerned that something's broken. The receiving shouldn't unpackage them there, and you shouldn't do it in central unless you've done an assessment of risk saying you are okay with assuming that risk, and the risk is very minimal. Compounding. So compounding would be reconstituting and mixing IV chemo medications. We've also, for our institution, considered compounding pouring out liquids just because there is a bit of a higher risk of spillage there. And that should be done in a primary engineering control located in a secondary engineering control. And then for administration, you need a closed system transfer device we use closed system transfer devices for reconstitution and preparation as well. Some I've heard that it can take a little bit longer, but our technician is very efficient, and she says it doesn't take any longer once you get used to it. It's just that transition to the closed system transfer device. Just like anything it can take a little bit of time, but once everyone's used to it, it's great. So these are examples of primary engineering controls. I'm not going to go through these because maybe you talked about them yesterday. So this is a biologic safety cabinet. So this is what you're going to want to compound the chemotherapy in, because it doesn't blow any air out at you. It sucks all the air down. So it keeps it sterile and it keeps it safe for you. I mean, your institutions have probably already implemented this in your IV room. This is just showing a picture of, on the left-hand side, the negative pressure room where you do chemotherapy. On the right-hand side, the normal IV room. And you have a hood in each of those areas. Closed system transfer devices. So just briefly, like we've mentioned, they offer additional protection for employees, staff, and patients to prevent any sort of chemo spill. They can also limit aerosolization. So the idea is these devices, you never are exposed to the liquid. From puncturing the vial to attaching it to the patient, you never see a drop of liquid exposed. And it's pretty neat. If you ever get the chance to look at them, they're pretty cool. They just kind of click together like Legos and transfer like that. There are no universal performance standards yet. So what that means is each different manufacturer has their own standards that they've set and probably published the amount of protection that they offer. But no one is requiring a certain amount of protection to be provided by these devices. They're not a substitute for primary engineering controls, so you still need to do this in primary engineering controls. They should be used when compounding, and they must be used when administering these medications, when possible. So these are some of the manufacturers and devices that are available. And you can see they're just plastic devices that click together. Nothing too fancy. And they really are easy to implement and easy to use once everybody's been trained. So personal protective equipment, we've basically talked about this. You probably talked about this yesterday. When compounding, you still have to follow all the USP 797 requirements. And then USP 800 requires you to wear a second pair of gloves that are tested for chemotherapy, the ASTM. You have to wear a second gown that is impermeable to chemotherapy. And then you have to wear a second pair of shoe covers that's also impermeable to chemotherapy. And then if there's a risk for splashes, you need to wear goggles. Because we use closed system transfer devices, we don't really have a risk for splashes, so our technicians are not wearing goggles when preparing this. Vial pressure, you should always maintain negative vial pressure, so that means you don't put air into the vial. If you're using a closed system transfer device, you don't really have to worry about that. You should prime the medications with normal saline or dextrose, whatever is the non-hazardous fluid, and then add the hazardous fluid to the bag. And then you should use closed system transfer devices. Disposal of PPE. PPE should be disposed of as chemotherapy waste. You should take off your hazardous PPE in the chemo room and then walk out of the chemo room and still have your non-hazardous PPE on. Dispensing, like we were talking about, chemotherapy should be labeled with some sort of sticker or some sort of tag on the label saying it's chemotherapy, hazardous medication, chemotherapy or hazardous medication. You must have packaging to protecting from damaging, leaking, anything like that. And when transporting chemotherapy, you need to transport it in containers that minimize the risk of spillage and leakage. So we have a lunchbox with a hard plastic shell that we transport all of our chemotherapy and any liquid hazardous medications in. Tablets, we still let technicians take up on routine delivery without the bin that we have. Administration, we've talked a little bit about this. It's a whole another lecture for nursing, but the tubing should be primed in the primary engineering control. You must wear PPE when administering. Closed system transfer devices must be used, and you shouldn't manipulate hazardous drugs on the floor, is the recommendation. So really what that means is nursing should probably not split tablets or capsules on the floor. I know that's a challenge. That's a big challenge for us with misoprostol that they use in labor and delivery, because the smallest size that the medication comes in is 100 micrograms. But our physicians and providers will order 25 micrograms. And so the nurses will split it twice on the floor, end up with maybe a quarter tablet and then a bunch of powder. So we are working on that right now. Any pharmaceutical company that wanted to make 25 microgram misoprostol would probably make a lot of money, but I don't have those resources to do that. So yeah. And then disposal needs to go in the yellow waste bins. Cleaning, compliance with 795 and 797, and you need to decontaminate, deactivate, and clean. And personnel must be trained in PPE and these cleaning procedures. So deactivation renders the compound inert or inactive. Decontamination removes any hazardous drug residue. And then cleaning and disinfecting remove any inorganic, organic, and microorganisms that are possibly there. So cleaning agents, so we use Paradox RTU for our deactivation, decontamination. And so in community pharmacies, you really would only need to use Paradox RTU or bleach wipes, and that will do your deactivation, decontamination. Cleaning, we also do because we need to be sterile, and then we sanitize, so we sterilize everything as best as possible with the isopropyl alcohol. So what departments and operations are governed by USP 800? And I'm going to go through this so we can get to more questions. All of them, everything at your organization is governed by USP 800. So additional requirements of USP 800, spill control. We have spill kits anywhere that hazardous drugs are administered and anywhere where hazardous drugs are received or prepared. You can buy spill kits from your suppliers. We've supplemented our spill kits with some additional things in there because we felt better having more rather than less. So we added a respirator that we had from COVID, and we added a spill sign, and then we added directions to tell everybody how to clean up these spills. You need SOPs or policies and procedures to document how to clean up these spills. And then if there's a spill, it's recommended, and you have contamination onto a person, it's recommended that medical surveillance follow up with that person. We're still working through that. That's not a must, that's a should in the USP 800. So application to community pharmacies, we briefly touched on this a little bit. In my opinion, and when community pharmacies have the audit by the Board of Pharmacy, they'll find out more, but in my opinion, community pharmacies just need an assessment of risk and need to segregate where they count out their tablets and capsules and then wipe it down with bleach or preempt afterwards. You don't have to have a negative pressure room to store these medications. You don't really have to store them in a separate room at all. They don't have to be on a separate shelf. They can just be in the normal stock. As long as you're doing an assessment of risk, explaining why you're doing things the way you are, and making sure that everyone is aware that these are hazardous medications, and they won't just spill them all over everywhere. The other thing that I didn't mention that USP 800 requires is for everybody who's working with hazardous medications to sign a sheet acknowledging that they're working with hazardous medications and that they are dangerous if you're exposed to them. And the recommendation is to have people sign that sheet every year just to remind them that yes, these hazardous medications are still there, yes, you're still working with them. Here are resources for further study. our summary. I won't run through this again. And so now, hopefully you feel a little better about USP 800 and you're not like these people on Reddit that hate the USP 800 committee. Yes, it's very daunting, but it is manageable, and I think everyone will be able to do it. Here are my references, and I'll take any additional questions that you all might have. I know we answered a lot in the middle, but yeah.
I just want to say thank you for all the hard work you're doing.
Oh, thank you, yeah. All right, well, thank you all. I'll stick around for a little bit. My brother's in town today, so I've got to run, but I'll hang out for a little bit. So thank you all. I really enjoyed getting to present, and it was a pleasure. I appreciate it.
Thank you.